Dear colleagues and friends, my name is Dr. Hom-Lay Wang. I'm the scientific co-chair of the AAP consensus on prevention and management of peri-implant diseases and conditions. And together with my scientific co-chair, Paul Rosen, we're going to do this very short kind of the introduction about what this is all about. So let me give my podium to Paul, and then I can then help you to understand why do we do this project. So Paul, you want to add in some ideas?
Thanks, Hom-Lay. It's really been a pleasure to work alongside with him in this entire endeavor. And Hom-Lay was more the representative of the Academy of Osseointegration, while I was the American Academy of Periodontology's representative. And this all was the brainchild of Hom-Lay's. It dated back about several years ago when we had a small subcommittee that was looking at endeavors to heighten awareness and treatment for peri-implantitis. And Hom-Lay had this idea, and at first I was reticent about it, but this has been a fabulous opportunity and great for our patients. So Hom-Lay, why don't you tell everyone, how did you come up with this idea, and what were your thoughts as to where the directions might head?
So I think this one of the idea for everybody in the private practice starting facing is the emergence of the peri-implantitis or peri-implant diseases, which is facing a lot of the things we place implant. It's a big challenge to us. And I think it's important for us to gather all the experts, not just the periodontists, but also including the prosthodontics, general dentists, oral surgeon, who does involve in the implant therapy. Together, we're going to bring the evidence base and also expert opinion and clinically orient practical guidelines to help our colleagues to understand how the peri-implant diseases and condition is all about, not only from the risk factor standpoint, but also from therapeutic approach. So that's the idea which I had, and I think luckily enough, I had the support from the Board of Trustee from AAP and also from the AO, so we can initiate that first one of its kind of this joint effort.
What was really good about this was that while it started being grounded in science, there was a certain aspect of this that was best evidence consensus, meaning that we took expert opinion as well, where there were areas of deficiency in the science. It was just lacking because it may not have been looked at. And we melded this together to try to come up with something that was practical. The timeline of this was incredibly short, and yet we were able to put together 41 participants. We had four of those were co-chairs for two sections, one being more towards the prevention guidelines and the other being more surgically oriented. And we distilled this down into several plenary sessions and came up with consensus on a number of issues, and others we didn't. So I think that the endeavor has been amazing. It will continue to move forward. And I think we should just briefly give you some snippets as to what we gleaned from this. And Hom-Lay, maybe you would go into the surgical end of things, and then I'll conclude a little bit more with some of the preventive.
So it's very interesting. And when we're looking into the management aspect, we started looking into the non-surgical treatment, which is the first step for us to treat the peri-implant mucositis. It's also the first step for us to manage the peri-implantitis. And so we dive in to talk about the methods and the current technology or techniques available for us to treat or the peri-implant mucositis, in particular focus on non-surgical approach. Then we focus on the surface debridement, which also surface decontamination. So we talk about all the different methods and technique available for us as a clinician to use to manage this type of a disease. So in this consensus, we actually talk about each things and come up with the flow diagram. And I will use the term called clinical roadmap to help our colleague to understand how do we use it. Then we talk about the surgical management, that including the non-reconstructive, such as osseous resective, which including implantoplasty, or the constructive, such as regeneration using different type of material or biological agent. And then we talk about soft tissue augmentation to manage some of these issues. So this actually very unique. We provide like Paul was saying, the expert opinion together with the best evidence support. So we came up with a lot of a flow diagram to guide our colleagues and friends to learn or to follow and to what we do in terms of manage of these peri-implant diseases from the non-surgical to the surgical aspect. So that's the surgical aspect.
So, Hom-Lay, were there one or two things that you gleaned that you could provide to anyone watching us that kind of surprised you, or you feel, clearly everyone should be availing themselves of the written materials, but were there any one or two you'd like to highlight from the surgical end?
Yeah, I think we talk about the aspect of the non-reconstructive approach. What's the pros and cons, such as we do a resective? Is that the available, or is that the evidence base? Is that clinical efficient? So we dive into and talk about this and provide some of the voting outcomes based upon the expert from all specialty. The other things which I was surprised to see is we do a reconstructive approach that also including applying in the soft tissue. Certainly, I think one of the highlight things is the supported peri-implant maintenance program, which is essential for the implant long-term stability and also for long-term result. So we talk about when do we see the patient and what procedure we should do during these SPIT procedures.
So, from my end, I'm going to address a little bit about the preventive nature of this conference. And we went through a variety of things. First, again, preventing peri-implantitis, preventing peri-implant mucositis, some of the soft tissue considerations. And one of the nice things, and Hom-Lay pointed this out in the beginning, was the fact that we had prosthodontists and restorative dentists involved in this, along with oral surgeons. But from having the restorative end, we talked about risks associated with the prosthetics. What we found were things such as that tissue level implants seem to have greater consensus for preventing peri-implant problems. One surprise was that cementation of restorations did not seem to show that there was a higher risk for peri-implant disease development, which was counterintuitive to what I would have thought. Another thing was about emergence angles. Greater than 30-degree emergence angles could be a problem. Height related to restorations as well. All these things factored in, and it's a beautiful read for us to better understand what we need to do in the surgical end of placement to try to mitigate these problems from occurring. Furthermore, we talked a bit about soft tissue considerations, and with soft tissue considerations, we addressed phenotype management, phenotype concerns associated with it, also improper positioning and the role that it can place by putting demands on the soft tissues that might create problems. From the risk markers of peri-implant mucositis and peri-implantitis, one of the things that had never really been talked about in the past that was mentioned was obesity, and the fact that obesity could be a risk indicator for peri-implant diseases. So there were a plethora of things that came about from this conference that I think you all need to read about. We can't possibly, in our very short time with you, go through all of these things, but this is a tremendous undertaking, and I think it bears a lot of clinical benefit for us to better understand not only how to first prevent it, but when it occurs, how to manage it. Are there
So
any? I'm sorry, Hom-Lay, but are there any things like you'd like to say to kind of cap off what we've been discussing for the past 5 minutes?
So what I'm trying to say is, as Paul said, it very nice. You got to read it. There's a lot of information you're going to gain from by reading it, and it's going to help you in your clinical practice. So my goal, and together with the task force and all the participants, is we put the information out. We hope that can help and benefit in your private practice and your patient care. So read the consensus report and let us know what do you think and how can this information help you and promote your private practice. Thank you very much.
Thank you as well.